design strategist and webinar coordinator at ASRM. This webinar was developed by the Society for Assisted Reproductive Technology and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Before we begin, please note, all attendees will be muted except the panelists. Please post a question in our Q&A window at any time. We will read as many selected questions as possible to the panelists. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Our moderator for today's session is Dr. Cristin Slater. Dr. Slater is a board-certified reproductive endocrinologist and infertility specialist. She works as a practicing physician and medical director at Idaho Center for Reproductive Medicine. She has published 3 chapters in medical textbooks and articles in prestigious medical journals. I'd also like to recognize Dr. Kelly Lynch, our pioneer or a proponent for these webinars. Thank you very much for being a part and supporting this effort. Over to Dr. Slater.
Thank you, Sarah. So today, hello and welcome to the ASRM webinar on gestational carrier cycles. I'm very excited about this, and we've got a panel of experts that have a passion and are very excited to teach and help you how to gestational carrier cycles to make this a very safe and effective way for family building. The webinar is entitled Gestational Carrier Arrangements When It Takes a Village to Build a Family. And I think we all know that you know, our duty is to help people have families, and it's a needed way to help build families. And the cycles are increasing. When I looked at the last SART data, which is Society of Assisted Reproductive Technology, a great resource for looking at IVF statistics, it gives you real authentic data. The last published data was in 2019, and there was over 9,000 cycles. So this is a needed way to build families, and it's growing. And I'm very pleased to introduce 3 experts that have a passion for fertility and help building families. We're going to talk to Dr. Ann Steiner, Dr. Carrie Eichberg, and Margaret Swain, who is a nurse and an attorney. They all have very good information that will help you understand and know how to do this, because it's not hard. It can be very safe and effective. So first, I'd like to introduce Dr. Ann Steiner, who is a reproductive endocrinologist, and she is also editor-in-chief Fertility and Sterility, and she was one of the co-authors for the guidelines for gestational carrier cycles. So we'll start off with the medical, and then we'll go to psychological and legal. Dr. Steiner.
Today, I'll be covering the medical aspect of gestational carrier arrangements. Specifically, we're going to talk about care of the intended parents or gamete donors, care of the gestational carrier or GC, psychoeducational screening and counseling. All this will be discussed in further detail by the other panelists, and legal considerations, once again, which will be further elaborated on by the other panelists. Let's get going. So the first thing to think of or consider are the indications for the use of a gestational carrier. We recommend, or considering the potential indications include absence of a uterus, congenital or acquired, significant uterine anomaly, absolute psychological or medical contraindication to pregnancy, serious psychological or medical condition that could be exacerbated by pregnancy or cause significant risk to the mother or fetus, biologic inability to conceive or bear a child, such as a single male or homosexual male couple, and finally, an unidentified endometrial factor, such as multiple unexplained previous IVF failures despite transfer of good quality embryos. So how are we going to care for the intended parents or gamete sources? So there are first things to think of the FDA requirements and then ASRM recommendations in addition to the FDA requirements. The FDA requirements are basically screening, our mechanisms to screen for infectious diseases. The requirements for the FDA screening for both the sperm and oocyte sources are a physical exam, a medical questionnaire, and laboratory testing. If you want further information about the specific physical exam and medical questionnaire, please see the prior practice document on gamete and embryo donation. There you can find the exact components to the physical exam and medical questionnaire for FDA screening. Please note that when you're screening the gamete source, either the sperm or oocyte, if you identify they screen positive, that designates them as ineligible technically, but you can, as long as you label, you can still and consent and inform the gestational carrier, those gametes can be used. So that's the FDA requirement related to caring for the intended parents. In addition, we recommend that the intended parents undergo psychological counseling, also have genetic screening because they will be providing the gametes for in vitro fertilization, that they undergo a medical evaluation to assure that they are capable or that they will be able to undergo an IVF cycle. And they need to make sure they understand the components of in vitro fertilization. And of course, they'll need a legal consultation prior to proceeding with the gestational carrier cycle. And important to remember that laws vary by state. More on this by Margaret. Let me see here. So what laboratory testing are you going to need to perform? I recommend that you go to the FDA website, always consult their website. But this is currently the recommended labs that should be obtained for the gamete donors for either the sperm or the egg, not donor, but intended parents. But we think of them in a way like a donor, a known donor. And these are the laboratory tests that you'll want to obtain. And it is important to remember that it needs to be at an FDA approved laboratory. So it's the exact same way of screening as you would a gamete donor. The next thing you need to be aware of is once you've done the IVF cycle regarding quarantining of embryos. This is not required by the FDA for use in a gestational carrier. However, we recommend that you offer to the gestational carrier the option of cryopreserving and quarantining the embryos for potentially 35 days, and then releasing the embryos after both sperm and egg source have been retested and have negative results. Now, regarding selecting the gestational carrier, ASRM recommends that carriers must be of legal age and preferably between the ages of 21 and 45 years. Ideally, the carrier should have had at least one term uncomplicated pregnancy, and they should have had no more than a total of 5 previous deliveries or 3 deliveries via cesarean section. And it's very important that carriers have a stable family environment with adequate support to help her cope with the additional stress of pregnancy. Additional screening and counseling of the gestational carriers includes first, a medical evaluation and counseling. During this medical evaluation, you're going to obviously make sure that she's okay to carry a pregnancy. And you'll also, during the counseling, want to inform her about the screening tests that she's going to undergo, the likely uterine evaluation that she will have, hormonal preparation, and embryo transfer. You'll also need to do infectious disease screening and testing. Now, And with this, you'll want to do it like you do with the gamete, with the intended parents, and that you'll want to do medical history screening, physical exam to screen, and laboratory testing. Now, a lot of people find that it's easiest to just use the FDA documents for this. In other words, the FDA recommended methods for screening via the medical history or questionnaire, and also the physical exam. The laboratory testing does not have to be done in an FDA-approved laboratory. If the gestational carrier does screen positive or have something concerning, that does not mean that they are ineligible per se. However, it is important that the gestational carrier and obviously the intended parents be informed. You'll additionally want to provide preconception testing and counseling, and the gestational carrier should have psychosocial evaluation and counseling. There should, of course, be legal counseling in place, and we recommend a uterine cavity evaluation. These are the recommended labs for infectious disease screening. We do recommend that both the gestational carrier and her partner be screened for a common infectious disease that could possibly be transferred to the fetus. Regarding preconception testing and counseling, you'll want to make sure you obtain a blood type and Rh factor. And if there is a potential for Rh incompatibility, the couple should be informed about the obstetric significance of this condition. The GC should undergo appropriate cervical cancer and mammogram screening, have titers for varicella and rubella, a urine drug screen, and all gestational carriers should be vaccinated against common diseases as recommended as per CDC guidelines. Regarding embryo transfer, ASRM highly recommends single embryo transfer, and at a minimum, the age-related limits on the number of embryos to be transferred should be followed. And therefore, in cycles for which the provider of the oocyte is over 38 years of age, we recommend potential use of things like pre-implantation genetic testing for aneuploidy, and then subsequent elective single euploid embryo transfer to hopefully decrease the temptation for multiple embryo transfer. So that's all I have today, and I thank you for your time.
Thank you, Anne. That was really helpful just to understand the screening to make sure things are safe for everyone involved. And next, I'm happy to present Dr. Carrie Eichberg, who is a licensed psychologist who specializes in reproductive psychology. And she's been doing this for over 20 years. So she is truly a seasoned veteran in reproductive psychology, and she has a passion for this also. She's written a book on third-party reproduction and mental health, and also with egg donors and surrogacy. She is an adjunct professor at the Department of Psychology in Boise State University, and she's done a lot of evaluations talking to the gestational carriers and talking to the intended parents. So she really knows, what is involved in the psychological aspect. And I think it's very important that we do the appropriate medical screening, we do the appropriate mental health evaluation, and just making sure everyone's sound with all the all of the pieces involved, and then with the legal aspects too. So I will hand this over to Dr. Eichberg.
Thank you, Dr. Slater. So today I'm going to be talking about the role of the mental health professional in the gestational carrier arrangements. And given our short amount of time, I'm really going to be talking about what we do, not go into the details of how we do it. So nothing to disclose. And first, I wanted to address who is doing this work. And of course, we recommend that folks who are going to be working with gestational carriers and intended parents be a member of ASRM and our mental health professional group. And in fact, ASRM has a practice committee document, and the title is guidance on qualifications for fertility counselors. So if you're ever wondering, what qualifies someone to do this work, ASRM does have a document on that. And in that document, we say that one of the first things is that you need to obviously have graduate training and you need to be licensed to practice. You also need training in psychological testing, and especially proficiency associated with third-party reproduction. And I'll be going into that a little bit later. But you also obviously need knowledge of the medical, legal, and the psychological aspects of infertility. And also post-licensure clinical experience in this population. And then always continuing education. And so one of the ways that ASRM, if you become a member, are a member for training, is that we have a mentorship program. There is also several different infertility courses, and there's actually an upcoming training at the Jefferson Infertility Conference, which is in Philadelphia. That's coming up, which is a great place to start. And they actually have training on one of our testing instruments, the PAI. So if anyone is looking to get trained in that, it's a great conference to start. Even though I have done hundreds of egg donor evaluations and gestational carrier evaluations, I still get consultation from colleagues. It's very important to know that you have a team of people who you can rely on to talk to, because there will always be and continue to be difficult cases. So I think it's important to be open to getting that consultation and recognizing that these are really high stakes evaluations. We're dealing with babies, a lot of money, issues of control, anxious parents. What could go wrong, right? So there's lots of ways that these could go sideways. So it's really important that you have the training, expertise to move forward and to jump into this work. I think one thing to really look out for is in the instruments that we use, which are typically the PAI, the Personality Assessment Inventory, or the MMPI, Minnesota Multiphasic Personality Inventory. Those companies spit out a test report, and it is not advisable to just use that test report. And I'll talk about that a little bit more when we talk about evaluating the gestational carrier. Okay, let's see. So for the carrier evaluation, the first thing that we do is we want to get some information. Is this a carrier that the intended parents know? Is this a carrier that they were matched through an agency? Or is this someone who they found on Craigslist? We want to understand, how did they first get to know this other person? And that gives us a lot of information about the type of interview, how many people will be involved, and so forth. So in terms of who is involved in the interview, we always have the carrier, her partner, her live-in partner, and also then we have the intended parents. And there is typically a joint meeting between intended parents and the gestational carrier and her partner. So there is a clinical interview that takes place. And a lot of times, I'm not going to go through the entire, what we do in a clinical interview. That's to be learned at a different time. But one of the things I do is I sort of play like a psychological lawyer. So we sort of look at worst case scenario. what would happen if you were on bed rest for 3 months? Who would help with your family? You know, what if you were in the hospital for an extended amount of time? So we really look at sort of the worst case so we can help them prepare to have the best case. So for the gestational carrier, we all have, carrier applicants have psychological testing. And as I said before, they're typically with 2 instruments, either the PAI or the MMPI. And these are broad evaluation of personality and psychopathology. It is not okay to use just a checklist like a depression screening that someone just checks off yes, no, or an anxiety. That is not what most, and it is not with our guidelines. So it is really important to have training in these tools, and not just in the tool, but how do our population of patients look on these? Because these tools are really meant for the general population. That's how they're built. But if you attend some of these advanced trainings, you'll understand, well, how does exactly a gestational carrier present? What happens? And we say, are they presenting as a saint or a superhero? Meaning, like, are they trying to put their best foot forward or not? We're able to take a look at that and evaluate that. Are they being an honest reporter? And as I mentioned before, there's also the joint meeting. And let me say, we will do psychological testing with the gestational carrier and her spouse or live-in partner. Okay, let's see. Moving on to the next one is the psychological screening limitations. What can it tell us? It can really tell us, does she meet ASRM guidelines? There are psychological guidelines that you can find on the website for gestational carriers. As I said before, is she really trying to look good? Is she presenting that she's the most perfect gestational carrier you've ever met? And also the presence or absence of psychopathology. And what are the personality factors and her coping styles that will help her get through the psychological, the process of being a gestational carrier? It can't really tell us what her relationship with the IPs will be. Can't guarantee you that it's going to be a problem-free surrogacy. And that her feelings and beliefs today will remain the same over time. Assessment is really, it's like taking a picture. It's a picture in time. Okay, let's see, moving on to the next one. So for the intended parents, some people view the meeting with the intended parents as a consultation and say that everyone really has a right to have a baby, and we're not going to say yes or no or anything like that, but it's really an educational meeting about surrogacy. And of course, if they're using any kind of donor gametes, the donor education piece would be included. There are other mental health professionals who think that we need to protect the surrogate as well, and that everyone has the same screening tools and has the same administration of the screening tools. So there are some mental health professionals that also give the MMPI or PAI to the intended parents. And those are just different choices and different ways that people use their run their practice. It is incredibly important to, at the outset, establish who has rights to what information. So that means having really solid consent forms and not just having people sign them, but reviewing them with them. So for example, you have a known situation where this is a friend who's going to be a gestational carrier for intended parents. And the intended parents are paying for the psychological screening of the carrier. So in your consent and discussion to be able to say, even though you are paying for this, you will not receive a copy of this report. But we will go over any concerns or red flags that come up in our joint meeting together. Other people do it different ways and have releases of information so that everybody can share everything. I don't, because sometimes there is something that will come up in an evaluation. So for example, the history of previous sexual abuse, and that maybe that gestational carrier got appropriate and helpful treatment, and that's no longer an issue. Well, it's important that we have noted that in our report, but that's not important for intended parents to know. So I always, the way I do it is that I am not willing to share that report with the intended parents. It's really for the doctor or the clinic. But again, there are different ways of doing that. It's just the clarity that we need to make sure that we have. And then, of course, there is the joint meeting. So also in talking about intended parents and carriers, so Margaret, you can give your opinion on this one, but sometimes I will say that your relationship is more important than your legal contract. And here's why. If you have a good relationship with your carrier, with your intended parents, you can get through many problems together and get through it smoothly. So it is critical that you have a good relationship, and mental health professionals can help with that. So finally, there's also ongoing support during pregnancy, which I highly recommend. A lot of times the lawyers will put in a psychology benefit. So meaning that the intended parents agree that the surrogate can visit, have visits with a mental health provider during the pregnancy. And I really think that's smart, because even during the best of circumstances, it's stressful to carry someone else's child, and issues come up, and having someone to talk to about that, I think is really important and helps with the mental health of the carrier and her family. And then of course, postpartum support. So even if everything went super well, having a place to put some closure on that, review what went well, what didn't, any outstanding issues, I think it's critically important, and I highly recommend that carriers do that, and that it's in their contract to do that. So that's it. If you have any questions for me, you are more than welcome to email me, and I'll also be available at the end for Q&A. So thank you very much.
Perfect. Thank you. And next we'll go on to the legal aspects, which is a huge aspect. And I think as long as you have people that are educating their patients medically and psychologically and legally, this can be a very transparent process, and it's very important. It's very complex, but if you educate people right, I think that it will, for the most part, you're going to have a very good, safe process. So now I'd like to introduce Peggy Swain, and she is a nurse and an attorney, and she specializes in reproductive law. She is the director of the ART Academy of Adoption and Assisted Reproductive Attorneys. So she's got a lot to teach us.
Thank you very much, Dr. Slater, and thank you to the other panelists as well. So I will admit that this picture is my son and his beautiful bride during their COVID wedding in our backyard, which we now refer to as the West Portico. But it's not just a gratuitous showing of this picture. There's a point to it. And if I can get my slides to advance, you will see what that point is. The physician art practice lawyer dance, and it is the dance, and we've got to get that rhythm right. So that's what I'll be talking about today. Sadly, I have nothing to disclose. At the conclusion of the presentation, you will be able to identify components of the working relationship between the REI practice and the art attorney, describe the action items for legal referral, and outline the elements of a legal consult. Okay, good. It looks like you all had the right answer, so thank you for that. The question was, even in known relationships where the parties say to you, oh, we've discussed all the terms, we are in agreement, and after all, we're sisters, we don't need a lawyer. Those kinds of arrangements especially need a lawyer. And Carrie referenced that those relationships are not only important, but perhaps more important than some of the language in the contract. It is critically important to keep those relationships intact, and a well-written contract that has been fairly negotiated with independent representation for the parties goes a long way in keeping that relationship friendly and hopefully happy, not just during a pregnancy, but for the many years afterwards when the parties are going to be continuing their close familial relationship. So in all third-party collaborative matters, except when the parties are using gametes from a cryobank where the rights of the donors have already been terminated, everyone needs representation. During fertility preservation procedures, although often time is very limited, it's important to get an attorney on board, particularly if there are unmarried partners and they are discussing creating embryos together. When a spouse wants to reproduce while separated from his or her spouse, and if there are divorced or divorcing patients who jointly own embryos in storage, and of course, if the parties have moved on to adoption. So it's important for the lawyers to know some of the details, not just of what is expected of the attorney, but what is going on with the patients relative to the medical practice. For instance, is there a particularly urgent timeline? All timelines are urgent, I understand that, but sometimes there is something in particular that we need to know about at the outset. What about accessibility to the patient? Is someone suffering from a disability and we're going to need to make special accommodations, for instance, or with international clients, how will we go about contacting them? And we need to be cognizant of the time difference and also the differences among the different cultures. And are we going to need to engage a translator? Who's going to pay for that? And how will that all be done efficiently so that all of us can get our needs met while we're representing the individual clients? Is there a relevant facility policy that we need to be aware of? For instance, are there only particular dispositional choices available for couples in gamete donation or in a gestational surrogacy arrangement where there are extra embryos left, and has that choice been carefully documented in the storage agreements with the facility? Now, what do you all need to know from us? So what is the legal process? How will the representation be effectuated? And then how will you know it has happened and that the legal portion of the ART process, whatever it is completed? What should the patient expect from the ART lawyer? What happens during that consultation? We'll talk about that in a minute. And you need to know what the anticipated date of that legal clearance is, or whatever resolution of a dispute or other bump in the road is going to happen, and how will you be notified. Sometimes it's difficult to tell you that at the beginning, and our answer usually is going to be as quickly as we can get the cooperation of all the parties and work out whatever the particular issue is. And then we will let you know, typically in writing, that this has been accomplished. So let's talk about that legal consult. What happens in our offices? The keystone of any legal process in ART is independent representation for the parties. These are friendly arrangements. Typically, they do not turn adversarial. Regardless of that, each party has a particular legal right and interest in the arrangement, and the attorney who represents that party has a duty to represent that party's interest in the arrangement. So at the end of the day, we all want to get to the same place, and the best way to do that is for each party to have a lawyer looking out for that party's rights. The lawyers talk with each other, and we are all aiming for collaboration while looking out for our own client's interest in the arrangement. And I will say that in the ASRM Practice Committee guidelines, when it discusses the legal part of surrogacy, gestational surrogacy arrangements, it has some of the strongest language pertaining to legal representation among any of the practice documents. And it says gestational carriers must have ongoing independent legal representation by an appropriately qualified ART attorney. So the attorney who represents the intended parents will be drafting the agreement in most cases, and then the attorney representing the surrogate will review the document and negotiate any changes on behalf of her client. The clients need to be educated about what it means to be in an attorney-client relationship. The client holds the privilege. So attorneys are not allowed to go out, just like you as medical professionals are not allowed to go out and divulge certain information about your patients or clients. We need to hold that very close to the vest, and only if the client waives the privilege can we have a discussion about the legal aspects of the particular arrangement with anyone else. What are the responsibilities of the attorney? This should be written out in a retainer agreement that the party reviews with the attorney and then signs. So there is documentation of what the attorney is going to do for the client in this particular case. Even though the intended parents will pay the fee for the attorney, the carrier also enters into a written agreement with the lawyer. It discloses in writing that the intended parents are paying the fee, but that does not affect the carrier's attorney's responsibilities to her. And to the carrier's spouse. The only allegiance that attorney has is to the carrier even though the intended parents are paying the fee. And then the retainer agreement will go on to discuss conflicts of interest and ask the carrier to waive the potential for conflict because of that fee payment. And the retainer will also discuss the expectations, not just of what the carrier or the intended parents can expect from the attorney, but also what the attorney expects from the client. Things like remaining in contact and responding within a certain amount of time to questions or to a review of documents that have been presented to the client. So the duties of the attorneys in these arrangements are to draft the agreements, discuss them with the clients, review each and every term, explain, answer questions, and then negotiate for changes between the attorneys on behalf of the clients. And sometimes that takes a while, and it needs to be a real negotiation of terms to ensure that the integrity of the process is protected and the rights of all the parties have also been fairly considered and bargained for. So it takes a while. And we are very well aware that the clock is ticking. So a word about that. We try really hard to accommodate the request of clients and the timelines that have been set up by the fertility practices. We recognize that they are important. And if a certain time period has passed, then the parties are probably going to have to wait another month to have that embryo transfer or the egg retrieval or whatever the procedure is. Having said that, though, rushing is what often leads to misunderstandings and sometimes mistakes. So we, as I said, are cognizant and try very hard to accommodate. It's just not always possible. So in particular, representing intended parents, drafting the contract, going over all of the terms, making sure all the questions are answered and that they understand what is going into that agreement. In particular, emphasizing that they are not in control of the medical aspects of any pregnancy. The surrogate cannot be compelled to undergo a medical procedure or refrain from undergoing a medical procedure, specifically termination of the pregnancy or fetal reduction. So within the contract, the carrier agrees to comply with the wishes of the parents, but when push comes to shove, she cannot be forced into doing that. There is no injunctive relief, and there is no possibility of forcing someone to undergo medical treatment against consent. The penalty is financial, and that will be laid out within the provisions of the contract, discussed with the carrier, and negotiated to a place where everyone is comfortable with the arrangement. Representing the donor or the surrogate involves, again, reviewing that contract and negotiating terms on behalf of the client, even if that negotiation involves certain promises that have been made by an agency about the reimbursement or other benefits that the participant is supposed to receive. Oftentimes, those conversations about benefits and reimbursements are conducted before the participant has been represented. So in most cases, they are not changed, but every once in a while, a donor or a surrogate misunderstood or had not really had the opportunity to think about the consequences of what she was agreeing to with the agency. So once again, for it to be a real contract that will hold up against scrutiny, all the terms have the capability of being negotiated. These are just some examples of legal issues, not just in surrogacy, but also in donation cases. The legal issues differ as among sperm, egg, and particularly embryo donors. However, all of the contracts include a waiver of rights and an acknowledgement that it is unlikely that any promises of anonymity can be construed as a guarantee over the life of the donor conceived person. That is a topic for a whole other discussion. Fertility preservation clients. Wow, these are very tough. You are hoping for the best, but you got to plan for the worst. Really important to have a discussion about last wills and disposition of any embryos or gametic material. What would this person want to have happen if the worst should occur? Really, really important that an experienced attorney who is familiar with the laws of the relevant state regarding posthumous reproduction or storage of gametes to be used for reproduction later has the opportunity to consult with the client. Time is critical, of course. Once again, important to have independent representation at a time when the especially unmarried partners are considering creating embryos. Good to discuss other options such as freezing just gametic material alone. The legal clearance letter written by the attorneys is the alert to the fertility practice that all of the legal issues have been resolved in the contract phase and the parties can begin the medical procedures. So, my friends, yes, it does take a village. And once you get that rhythm right, things do tend to go a lot more smoothly. So thank you very much for your attention.
Oh, thank you, Peggy.
You're welcome.
I was just agreeing. Like, if you educate people on all of the aspects, you educate people on the frozen transfer, what the expectations are for a positive pregnancy test, and to the carrier, what their risks are, and from a psychological aspect, to make sure everyone has discussed and has a good relationship and good realistic expectations, and from a legal aspect, you talk about, best case scenario, worst case scenario. I think that this is a very safe option to do. And I can't emphasize what you said about educating everyone, because if you educate people and you have experts doing this, it's a wonderful option for people to build families. And so next we'll take some questions. I know we've got some good questions. Let's just see. So the first one was Ashley, and she was just asking about what a cycle refers to. Because we said gestational carrier cycles. And I'll just answer this, and the next we'll go to all the panelists. But I think a cycle just refers to, that treatment month where the gestational carrier is taking her estrogen and progesterone, and you put the embryo in. Of course, we do all the pre-cycle testing for the screening, the psychological, legal, but the cycles, the estrogen and progesterone, and you put an embryo in, and does it work? Let's see, another good, this is a great question. There's one with, we'll talk about COVID third. So then the second question is, can you explain the rationale? This is for Dr. Steiner. Can you explain the rationale of the 35-day quarantine? And I think they were referring to, so if intended parents, they create these embryos and they're frozen and they've gotten their FDA screening before, and then you wait 35 days and then you offer again for the egg and sperm to screen for infections? Is that the guidelines?
Yeah, so basically ASRM recommends that you offer to the gestational carrier the option of quarantining, but it certainly doesn't have to be done. But if they choose to do quarantining, the reason behind the 35 days is because remember we had this issue where you can get a false negative on HIV and hepatitis. And it is, they've now done all these studies. And so we got the CDC to provide some recommendation on this. And looking at the literature, it looks like if you had a false negative with that first one, after 35 days, you should test positive. So that is the reason for the 35 days. And when I say test false negative, it just means like they may have it, but the test is unable to detect it at that time. And so the initial test and then 35 days later, and that's why we chose the 35-day cutoff.
Great, extra reassurance for that to be negative. And so the next question, again, another good question. So it's for guidelines for a surrogate with COVID. So so I guess, do they have to, do the gestational carriers have to be vaccinated? And if you have a gestational carrier that says she had COVID a few months ago, you know, I know this is a fluid thing and things are changing, but as far as ASRM and guidelines and safety, what would you recommend?
So the ASRM, what we, in discussion about this, felt strongly that CDC guidelines should be followed. So currently the CDC recommends that everybody be vaccinated, and also just as everybody should be vaccinated against chickenpox or varicella if they're not immune, and rubella if they're not immune. So we think this is all within our standards that we've done throughout the years. And if the gestational carrier is not willing to be vaccinated, we think that is a reason to not use that gestational carrier. But that's our standpoint, I guess. It can be something that could be discussed in a legal contract. In fact, we recommend that it actually be put in the legal contract in case there's any, you know, during the pregnancy need for any vaccinations. But, you know, obviously the COVID vaccine we recommend right now prior to proceeding with the in vitro fertilization cycle. So that would be the recommendation of by ASRM.
That makes sense, going along with other vaccination recommendations for pregnancy. And this is for Dr. Eichberg. So with the psychology consultation, you know, you do the psychology consultation with the gestational carrier and you do it with the intended parent. Is it recommended to do a joint one also all the time, certain times, if there's an agency involved? I mean, I know there's reality and practicality, but what do you think?
I would say that it's recommended all the time because I think there are important psychological issues that should be addressed, that the qualifications of a mental health professional can, you know, discuss in that meeting, that not agency owners or things like that don't always, it doesn't always happen that way, but that is best practice.
Yeah, no, I think like you said, communication is key. It helps in so many arenas in life. And if you're communicating, so it makes sense if you're doing a joint psychological, you know, consultation. I think we've got one more question and it says, can you please elaborate on GC screening related to the GC's motive? Oh yeah, so Dr. Eichberg, what type of people come to you to be a gestational carrier? Like you probably have a sense after 20 years, like who are these people? Why do they want to be? And so this question ties into that. Can you elaborate on GC screening related to the GC's motive about being a carrier, about compensation, and just ethical concerns about the socioeconomic differences between an intended parent and gestational carrier?
Sure. So I see in the chat, there's also a question about financial stability. And yes, it is important that the gestational carrier be financially stable, because we're always looking for coercion. Is there any emotional coercion, or is there any financial coercion? There's also the risk, we say that most agencies will say, We don't take a carrier that is on government assistance. And
Mhm.
there's also risk because if on their taxes, they report that they have this income from the surrogacy, they could potentially lose their assistance.
Mhm.
And so we don't want that to happen. It also, as I said before, relates to coercion. So how do we evaluate it? We use our clinical skills and our testing skills. But, if somebody comes to us and says, I want to be a carrier, and how soon can we get that going? Because my rent is due next month. It's not really something that we would move forward with. Most gestational carriers, it's hard to say, but I can tell you, usually they're women, younger women that really enjoyed pregnancy. Maybe they're staying at home to be a stay-at-home mom, and they're saving to buy a home. Maybe they are in school and, they have kids at home, or they could even be employed. But they've really enjoyed pregnancy, and they feel like, it would be a great help to somebody else. And it would also be financially beneficial to them. Like maybe it would help them with the down payment on a house or school loans. But what's different in the US is that usually they're not going to get rich on being a surrogate. It should be a financial help, and huge amounts of money paid to a surrogate really are concerning because it can lead to coercion.
Yeah, makes sense. So this is a question for Dr. Steiner. And so we all know when carriers are healthy and they're the perfect candidate, great, that's an easy decision. But then when you get, you get these candidates that come to you and there's other health issues, like how many C-sections is allowed? What about if they've had a blood clot during pregnancy? And how do you determine, yes or no, or counsel, the intended parent, the gestational carrier?
These are great questions. One of them is easy. Our recommendation is no more than 3 prior C-sections. And the other ones, I'm not going to give a direct answer to. I think that's going to be a case by case and a discussion with both the intended parents and the gestational carrier. A prior DVT, she's going to need now heparin throughout, during the entire pregnancy or sub-Q Lovenox. And what's her risk of another DVT, even with the heparin? What's the risk with the heparin? Is that a risk that's really reasonable to take in this situation? And it may be that the intended parents also don't want to deal with those risks. I think that's perfectly reasonable for an intended parent to say, they should be made aware, okay, this person's had a prior DVT. And so they're going to need to be on all these therapies. Is this really somebody you want to use? So unfortunately, we provide some concrete for relatively common things like number of prior deliveries, number of prior C-sections, but these are going to be a case by case. And may need an MFM to be pulled into this situation, and the psychologist and even the lawyer. What do the panelists think? Do they agree with me?
I think where we often see the most difficult of these situations is when it's a known gestational carrier, that friend or that sister, and they really, really want to work together. And the surrogate's a lot more likely to say, I'm going to be fine. I just know it's just going to be fine. And it's pretty scary, I think. So yes, case by case is clearly what happens.
I'd like to
Right.
I'd like to just build on that by what Peggy said, is that we sometimes run into problems in known situations or in situations where the agency has introduced the surrogate to the intended parents and they've fallen in love.
Mm-hmm.
And then we get to psychology and there are significant concerns. And what happens then is that they stop listening to the experts and they are trusting their own judgment on, this relationship that they feel like is perfect. And that can run us into some really big problems. Would you say, Peggy?
Yes. 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 We have a lot of hard conversations in the lawyer's office.
Yeah, and it's great that you're having conversations because you have to educate people. And it's good that we have guidelines and we follow those. And if there are soft call things, I think if everyone knows the risks and benefits and is educated and it's a safe thing, then it's like life, you know, it makes sense to go on if all parties agree.
Mhm.
So, and I do want to thank everyone. These questions have been wonderful. And basically, I want to thank you, Dr. Steiner, Dr. Eichberg, and Peggy Swain. I mean, all the experts in the field. And it just makes you realize, like, if you have experts like this, and it can happen, and just educate the patients. And this is a needed field for reproductive medicine. Like, this is not as common as other things, but it is needed. And I think that we should all, you know, be proud that we're helping build families in these different ways. And I hope that this did provide insight for everyone of the aspects involved.
Thank
I
you.
just want to thank everyone for joining. Yeah, thank you. If anyone has questions, you can certainly, you can email any of the panelists or just go to ASRM. And my email is Cristin.Slater@idahoreproductive.com. But you can find us. But we just want to let you know, just email or call us and we'll help you. And this can be a doable option. But thank you for everyone for showing your interest.
Thank you.
Thank you, Dr. Slater.
Thank you. Thank you, everyone. Have a good night. Take care.
We're over our time, and thank you for moderating such an engaging session. And thank you to our panelists for bringing such a timely topic up for discussion. To our attendees, thank you for joining us. If we have not been able to answer any questions that you had, please drop us an email to webinars@asrm.org. This session was recorded and will be available on our ASRM website in the near future. You will receive a survey right after this webinar, and as a follow-up email, your feedback helps us give you the most relevant content, and your input is appreciated. This session, again, like I said, was recorded, and if you have any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. Thank you, everyone. Have a good night. This concludes the webinar.